Long been talk about over-reliance on donor funding and problems with siloed approaches to HIV programs, and having different bits of programs sort of siloed and fragmented, and how that's inefficient and can be wasteful. And also with the introduction of new products, long-acting interventions, dapivirine rings, and added to the meaning that really there's finally a great amount of choice for people who want HIV prevention. This is the perfect time to be doing this series. It's going to bring together some innovative thinking and experience from across a whole range of countries and communities and settings that's really going to help set a course for the next maybe 5 to 10 years as people really build sustainable, integrated HIV prevention. But then obviously January 2025 happened, and instead of having a perhaps 5 to 10 year roadmap for a transition to sustainable prevention, the need was incredibly urgent. These gaps that I thought the series would address weren't something that could be worked on over time. The gaps were just here now, and having measurable, demonstrable impact on communities, on service providers at that very moment. So really it became an essential project, I thought at the time. But at the same time, with that changing, with that seismic change in the context of the series, I really thought the idea that we initially had of launching the series at ICASA, at this conference, was going to be something very difficult to achieve, given the rethinking that might be required with the changing context. But after a meeting in Longway in February, where a lot of people were reacting to the events of January, and really sort of just coming to terms with that, the authors realized the importance of delivering this series now, and have really pulled out all the stops to deliver this important series. And I'm really pleased with the product that we have, in that it does these things. It does address the issues of introducing new products. It does address how to reimagine systems to introduce new products, involving communities, working with service providers, so that there's not such a great reliance on external funders, and so that things can be introduced fairly and equitably. So I really think that, remarkably, the gaps that I thought this series was going to fill, the questions that I thought it was address, it has done in a really short amount of time, in a tumultuous time. And yeah, so I think it's
yeah, I'll say it again, just an incredibly great project. And just finally, my final thoughts are what I really hope people who are looking at the series, who are reading the series and digesting the series, take from it is that now is a time to act, now is a time to take on board the series and really challenge your ways of thinking. We can't go on doing things the way we have done them. You've got to look at the series, look at the recommendations, recognize the huge amounts of thought and insight that is presented in the series from the examples given, and really open your mind to new possibilities, have discussions, reach out to authors and contributors and people working in the programs that are given as examples, and try to learn from each other as you build going forward, building back something different, sustainable, equitable. And the other key message, I think, is really, as we say so many times, engage with communities. You cannot achieve anything in HIV without bringing the communities with you, without letting the communities lead, without, whenever you want to do something, approach the communities at the start, see what they need, see what is going to bring them along with you, and acknowledge the contribution of communities and reward the contribution of communities. And that's all I'd really like to say. So thank you very much for giving me this time, and yeah, thank you.
Thank you very much, Peter. If you could have a seat, we might come. I've got some snazzy technology here, which I think is going to allow us to link Zoe in. Just going to see if the tech is going to. Also, just a plug to people watching virtually, I have something here where I can see your questions. So if you do want to contribute virtually, please do type in the chat, and I can see it here and bring it into the conversation. We're just going to give it 30 seconds and see if Zoe can come in.
Can anyone hear me yet? Anyone hear me yet?
Oh, we heard her and we saw her briefly.
We heard her and we saw her briefly.
And there's some echo. Zoe, can you hear us?
Yes, I can. Can you hear me?
Oh, I saw your mouth move, so I think you can hear us. We can see you in the room. We can't hear you yet. So we're just going to wait for everything to align and work perfectly. Whilst we're waiting, let me just say I'm really jealous, by the way. In my specialism, I don't have anything like this series where everything and all the lessons learned and recommendations are so easily laid out for you. So I hope you really do take the time to read through the series and absorb all that knowledge. Let's try one more time. Zoe, can we hear you? Can you hear us?
Yes, loud and clear.
No. Okay, we're going to try again. Peter, if you could grab a microphone. I did have one question for you. We had Dr. Landry yesterday, who is the director for the Centre on Primary Healthcare from the Africa CDC. In a lot of what you were saying, I didn't quite hear your thoughts on integration with primary health centres and where that comes up in these series, or if you could share your view. Thank you.
Yes. Well, this is something that I think Zoe was probably going to speak about a bit more. So I think, I mean, really, there's so many opportunities for integration across different health interventions. So within primary care, giving people, having discussions about HIV within primary care, but that really requires a lot of work in enabling and empowering primary care providers to have those conversations. There's big issues around, stigma and discrimination that need to be tackled to enable integration of HIV care into primary care and other healthcare settings. But it really is achievable. I mean, there are lots of examples of it happening. I think it's paper 2 in the series that tackles this issue, and it is addressed elsewhere in the series. So I mean, there's so many opportunities. People are accessing healthcare for many different reasons, and if we can just open up conversations about HIV within those settings, there's a huge opportunity to improve efficiency and sustainability.
Thank you. Please stay here on our shared microphone. Let me just try one more time with Zoe.
Yeah, I
Hello,
can hear
Zoe,
you
can
all
you hear
really
us?
well.
If not, I've got
Yeah,
another filler question for Peter, which is for people in the room that weren't authors and people like me who are jealous and would like to be published in the Lancet, what are the routes, what are the avenues open for people to publish, to write, to find other authors to contribute with?
I mean, we are contactable through the Lancet, and we are always open to your great ideas for series and projects and papers. We would very much welcome reflections on this series. There are opportunities to write comments or correspondence that you could submit to our journals. We like to think that we are, you know, vessels for exchanging ideas, for conveying ideas, for helping people relate their messages, for helping people to hone their messages. And so we're very, very open to that, and we really welcome. We don't ever want to publish something and that be the end of the discussion about it. We want things we publish to start discussions, to inspire new thoughts, to inspire new ideas, and we're always ecstatic to hear more about those. So if you do have any reactions to the series, then you can reach out to us through our correspondence section, for example, or reach out to us as editors. And we're always open to ideas for projects. We can't always do everything, but we are very keen to hear your ideas, and we'll always try and find some way of working with people.
Thank you very much. I have no more filler questions for you, Peter, so I really hope that this works this time. Can we try one more time hearing Zoe in the room? Zoe, can you hear?
Hello. I can hear you, but I just don't know whether you can hear me. Sorry. Hello, can you hear me now? No, I can't hear you. Okay. Dana says you can hear me, so I can't hear you, but I'm just going to speak. So hopefully I'm not talking over the top of anybody else. But I was asked to speak a little bit on the integration into primary care and the wider health system. And I think from my perspective of someone who's sort of coming from the global health community more than the HIV community, the idea that HIV prevention should be an integral component of wider national efforts towards primary prevention and a sort of life course approach to healthcare is a bit of a no-brainer, really. So what I think the series does, particularly paper 2, as Peter said, is to make the case to the HIV community that there's really nothing to lose and everything to gain by considering that the key facets of HIV prevention, so things like prioritizing and tailoring services, demand generation, quality and accessible delivery, and support for the sustained use of prevention products, actually map very neatly onto public health frameworks and therefore onto wider primary health care. So what I particularly like about the series approach is, as also I think Peter alluded to, is the judicious use of real country examples to make the case for how the really challenging shifts that are going to be needed in governance, financing and leadership could be achieved in different contexts. And finally, I think it makes a really strong case for the terrible wasteful nature of fragmented, overlapping and uncoordinated vertical programs in this era, as Peter mentioned again, of these drastically reduced external funding. So HIV needs to be brought under the auspices of national health systems, or risk the loss of essential services, of accountability and resilience as this donor money evaporates. So I'll leave it there. I think maybe, hopefully you can still hear me. I've lost you, but thank you for having me. I'm sorry I can't be there in person.
more about accountability agents. Community-led monitoring, as we all know it, is such a powerful mechanism that should not be, unfortunately, it's more of donor dependent. Most of the community-led monitoring initiatives are donor funded, depending on donors. And when the pull out or the stop work order or the executive orders came, we found most of them in those initiatives almost dying down. So in this series, we are calling upon governments to institutionalize the role of communities as accountability agents to make sure that the community-led monitoring is a core part of the sustainable HIV as well as broader health programming. And how can communities be empowered to do this? Yes, it could be legislated or a policy that they should be accountability agents, but without any resources, it's difficult. So we're also calling upon governments to basically develop or legislate policies that support social contracting. One of the papers is asking, or especially the one for systematic community engagement, is asking for social contracting so that there would be an allowance for public financing of the CSOs through local grants. And we know it's not easy, especially if a government cannot meet all the needs, especially treatment needs. To think of putting money towards prevention through a social contracting mechanism, it can be daunting. But what I would say is that what we are calling for is a systematic way to think of this as a possible thing. Some countries have examples of Zimbabwe through the AIDS levy. We have Namibia, we have Uganda. There are countries that are already implementing social